you know, so on and so forth, this is increasing the workforce to be able to support people.
Thank you.
Mhm.
Can you talk a little bit about the expected geographic reach of um, the people who would be trained through the program?
Yeah, absolutely. So this is statewide. So this is Newcastle County, Kent County, and Sussex County working with the current EMS agencies, in addition to Christiana Care and possibly Nemours and others. So this is really looking at the population. So we did a lot of interviews across the different agencies and the private care to ask them about the advanced training. We did some studying of Boston, who has rolled out a huge program around doing paramedicine and community medicine, and have seen just significant increases in people being, sorry, decreases in the emergency room, but also being able to help people with their needs directly where they are.
Great.
So
Madam
this is a statewide initiative. And one other thing I wanted to add is we're asking for this funding this year, but we are also looking into how do we make sure that this is sustainable long term, right? So we've been doing some research in the apprentice program. We have a different grant in which we are shepherding now through a different area around how to change paramedics into apprenticeship program so that it's eligible for federal funds in the future.
Madam Secretary, if I can ask a question.
Please jump in.
Okay, thank you. I apologize. I'm trying to raise my hand, but for whatever reason, it's not populating. So nice to see you, Stephanie. I think you are absolutely hitting on a on positions in the state of Delaware that we are trying to boost. There are long waits in our emergency rooms, and our hospitals are doing the best that they can. But I am a firm believer that people rest and restoring themselves in their own individual environment certainly is far better for a person's well-being. So just so that way I understand a little bit better, because I know you only had 2 minutes to kind of give us this briefing. So the what you're trying to do is, are you recruiting folks to then become paramedics and to get out to our communities? Can you just give us like
Yeah.
high level view of that so we understand it better?
Yes, so the upskilling is really around existing paramedics. So
Okay.
someone already is a paramedic. They're looking to expand their skill set and go into critical care or community paramedicine, right? So you're already a paramedic in order to go into this program.
Okay.
Now we are looking at how do we couple it. So say what someone is going through to become a new paramedic, they would still have to meet that baseline before going into this advanced specialty.
Okay. And is it true, like in the state of Delaware, we have there's different levels, right? So there's like a certification for some paramedics. Then you have folks that are riding the ambulances in our fire companies that are not considered paramedics, but yet have some of the clinical background.
Yep. So I think you're talking about a EMT versus
Yeah.
EMS, right?
Thank you. Yes.
So right now in the state of Delaware, we train specifically for 911 paramedics, right?
Hmm.
This is think about people that go to the hospital because they're checking their um, blood sugar.
Yeah.
And the first thing they do is go to the emergency room. Community medicine is will come to you,
Yeah.
right? So it would avoid a lot of the traffic going into the emergency room for non-emergency. I think the research shows that 40% of, I think it's higher than that, of people that go into the emergency room is really not an emergency. So this is tackling or helping to build our workforce to address the non-emergency visits to the emergency room.
Okay, awesome. Thank you so much.
Thank you.
Okay, barring other questions, thank you so much. James, let's move to the next presenter.
Absolutely. Next, we have the Community Educations Building, who joining us is Linda Jennings. And I know you had said that Aaron, all right, great. She's on and she's able to share screen. Perfect. Thank you. If you want to move that mic, it should be able to pick you up, but if you want to just.
Okay. Hi, good afternoon. Good afternoon, Madam Secretary. Hi, Stephanie. Just wanted to, so my name is Hassan Mohammed. I'm the Chief Strategy Officer at the Community Education Building, joined with Linda Jennings, the CEO, and Lynn Biddle-Cloud, who's our Director of Development. So what I'll be presenting is,
You're okay. Thank you.
Okay. Is a thriving futures ecosystem. So it really is looking at closing the gaps for students and families, especially high school students, around health and wellness in order to close achievement and attendance gaps. So there's a critical gap in access to health care for our high school students in our building and their families. We see it every day. Without consistent care, families are navigating housing or food insecurity, schools doing everything they can to hold it together. So the CB is uniquely positioned to close that gap through our Thriving Futures ecosystem. It's an integrated model connecting education, health, and social supports. We're a 9-story building in the heart of Wilmington with 4 schools and 7 nonprofits, organizations in one building. Code Differently is one of them, along with our direct service supports, which are student advocacy, which is like a student navigation and wayfinding supports for students, family resources, food services, and backbone supports. We've already seen how effective our model can be through our K-8 school-based health center and wraparound supports for K-12 that was established with Christiana Care that only serves our K-8 students. So what we are here to present is targeted funding, asking for targeted funding to advance our student navigational supports, our behavioral health supports, and introduce school-based health services for our charter high school, which serves 150 students. So I don't know if we can bring up, I would give you a little bit of a story so you understand what this looks like. So let's meet Maya. Is Maya there? Okay, Maya. So Maya graduated in 2024. She lives with her mom, stable home, mentally and physically healthy, accepted in plans to attend Delaware State University, graduated and walked on time, works a part-time job, attended her prom. 8 months prior to that, Maya, parents had just separated. She was unhoused, was living with friends on a couch. She was struggling with her academics and was having increased mental health challenges. She was through a navigator, a student advocate, who was her trusted person, learned that she had learned that she had an undiagnosed reproductive health challenge. She was connected to a mental health supports. She actually ended up doing 2 months of outpatient support. She was struggling with food security. All of that she learned through the navigator, and through connection through the school. That navigator was able to support her with getting through guidance with Delaware Guidance, who's also in the building, to offsite support, make sure she had all of her homework, everything that she needed, so that she was able to graduate on time. Get her to offsite supports for her physical health. If the school-based health services had been available, that would have been right there in the building as well. And so as a result, over 8 months, she was able to stabilize, graduate, and et cetera. And so there's 150 students like Maya in our building that don't have access to those supports. We are looking to establish 4 key pebbles that are necessary: that navigation, the family resource coordination, in establishing school-based health services with Delaware Health Equity Coalition, and then building out more partnerships and peer health education to sustain those efforts long-term. With the long-term vision and plan to extend this to the 1,200 plus students and families that we serve within the building and in the surrounding community. Our framework is a cradle to career framework. Through our partnership with Christiana Care, able to serve K through 8, we have enrolled 70% of the students, and is proving the power of access within the school walls. And this intense engagement also means that it reduces cost for medical providers, and it also reduces the amount of emergency visits, use of urgent care, because you have those resources, and that you have deep engagement to reduce some of the social determinants of health, which are obviously housing, transportation, all of those things that we look to focus on. Here we're focusing on our ecosystem aims to focus on all of these elements to provide holistic support. But we are focused in this one on
Linda,
those
sorry
four
to
areas.
interrupt, but if
Yes.
just maybe
2 minutes is done.
one more minute to wrap up.
No, it's no problem.
Okay.
I will wrap up just by saying that we recognize and believe we're uniquely positioned to provide the support at a pretty extensive rate. We aim to reach 70% of adolescents to improve chronic disease management, 25% reduction in vaping and initiation. These are identified areas by the school nurse, by the principals, 40% decrease in behavioral health disciplinary incidents, a 15% drop in chronic absenteeism, and 15% knowledge gain in healthy behaviors. These are the projected outcomes and impacts that we're looking to improve with this funding. And our partner would be Delaware Health Equity Empowerment Coalition, that is also deeply embedded in the community, and its vision is to eradicate health and social disparities.
Thank you so much for that. Questions from the committee? Can you give us just a couple of words on the sustainability plan beyond the sort of investment that we're able to provide, maybe able to provide here?
Absolutely. Do you want to take that? Okay. So we have. Okay.
I think, so right now, we have for the past 5 years been very focused on that Cradle to Career support network. And we're discovering that that's actually a national network that's being funded both through national funders across the nation. And we've been working with the Harley Coalition and have good vision that work will be funded in the next couple of years. So that is the biggest one on the advocacy side. The schools right now, KUBA, the K-8 school, has access to the wraparound grants, and that work is currently being funded. So as long as those funds remain steady, it will keep us focused on the K-8. And so we're looking for the high school sustainability. That's what we're working on. Again, part of our Cradle to Career. The DHEC has a plan for expansion, starting with Great Oaks as a school-based health center, but really joining us in our community as a community wellness center, as a second site for them. And so our plan with them is to start with the Great Oaks students, then expand to the University of Delaware students, expand to serving the families in the building. And then when our Youth Development Center opens this January, we will also be in a position and have space for them to provide services to the community as a whole.
Great. Thank you so much.
You can.
Okay.
I was going to add that with the community wellness model as well, then that is a larger number of students and families served. Adult services provides more sustainability from billing standpoint. We have 70% Medicaid eligibility within the building in terms of our student and family population. And also, we've had grant and aid contract with DHSS, our additional leases, and other funds that we've been able to procure. And then CB's contribution is being able to provide the physical space and administrative costs.
Great, great. Okay, thank you so much. All right, James, who's next?
Next, we have the Delaware Breast Cancer Coalition, who had, it was listed on the agenda. They have 2 different applications. So I don't know if Francesca Vogel or Sue Murray, which of you would like to go first?
Thank you, James. And would you like us to present one proposal and then allow for questions, or just kind of run through both together?
Why don't we do both together and then we can do questions?
Okay, sure. And thank you, everyone. Our mission at the Delaware Breast Cancer Coalition is to empower our community by raising awareness of breast health issues and increasing access to care through outreach, education, and support services. And that is in order to facilitate the early detection and treatment of breast cancer. Our Women's Health Mobile Health Screening Program addresses community needs in all 3 counties, providing vital preventative screening services and healthcare intervention to medically underserved communities statewide, and meeting the need for culturally relevant programs that meet people where they live, work, and worship. The program proactively concentrates on screening navigation for patients to a vast statewide network of standing mammography screening sites, hospitals, and advances health equity in partnership with health organizations, including the Delaware Division of Public Health Screening for Life program. Cancer prevention activities are focused on census tracts that are identified as having high incidence of cancer, along with late-stage breast cancer. Women's mobile health screening addresses these health inequities and needs to overcome social determinants of health barriers by removing obstacles to screening and healthcare that are often stumbling blocks for many underserved and rarely screened or never screened women. Those may include language translation, lack of transportation, being uninsured or underinsured, lack of primary care provider, lack of health education, or fear of the healthcare system. Women's mobile health screening further is driven by a need for outreach programs that include education promoting healthy nutritional lifestyle habits to reduce the risks of cancer and chronic illness and promote healthier lifestyle choices. So the women's health screening model delivers a holistic and evidence-based approach that addresses these community health needs by the following. Our team of women's health screening patient navigators schedule screenings and conduct follow-up for patients and provide translation services in Spanish and Haitian Creole, and they are certified medical healthcare interpreters. This ensures culturally relevant programming is deployed and screening appointments are kept. We provide transportation to screenings and treatments as needed. We facilitate and assist with patients with applications completion for the submission of Screening for Life insurance and schedule Screening for Life appointments. We have added a community health worker to complement our women's health screening efforts to address social determinant of health needs, addressing imminent food, housing, and other family needs to provide relief to women so they can prioritize their healthcare needs that would otherwise derail their own mammography screenings. Under DBCC's umbrella of services, women's health screening provides patient referrals to survivorship programming, peer mentoring, and Yes to Health programs as a one-stop hub along the continuum of breast cancer journey. I'll direct you for our key outcomes to question number 5 at the bottom of our proposal on pages 5 and 6 for specific tracking and racial ethnic groups that are targeted, as well as vulnerable patient groups in concern for time. But to summarize, our very concentrated and deliberate women's health screening efforts result in building culturally relevant, trust-based relationships with patients by removing barriers impeding their health care to ensure that patients who wouldn't otherwise receive life-saving screenings obtain the resources they need. Our ultimate goal, of course, is to increase mammography screening rates over the prior year among these target groups to detect breast cancer in early stages when it is easier and less costly to treat, correlating to a decrease in related breast cancer mortality rates throughout Delaware. As these efforts are very core to our mission, DBCC takes these efforts so seriously as to subsidize the total cost of running the state contract for women's health screening with a 35% contribution to cover total program costs. Okay, I'll move on to our DBCC outreach program. This program exists to impart the importance of timely screenings and breast health and wellness knowledge throughout our statewide communities as a pipeline to DBCC's women's health screening and survivorship programs. Outreach addresses community health needs through two key areas: expanding access to health care for uninsured Delawareans and promoting preventative care in order to detect breast cancer and avoid adverse health conditions. Our expanded outreach efforts are meeting these identified needs by providing measurable, comprehensive wellness programs that address breast cancer risk and reduction. DBCC's outreach provides culturally competent education and wellness programs that focus on risk factors associated with breast cancer, the importance of early detection, and the power of screening over cancer. Outreach also provides a holistic referral system to both our internal women's health screening to connect the community to screening resources and survivorship programs for support and resources that address the full spectrum of needs in the community. DBCC recognizes collaboration with other health-focused organizations is essential in reaching the entire state and cultivates trusted relationships with government, hospitals, other nonprofit agencies, and private partnerships that are all delineated on page 8 for a comprehensive list of partnerships. So to sum up, our deliverables include basic breast health education, screening information, and screening for life resources deployed through health, wellness fairs, faith-based organizations, work sites, cultural festivals, and community events. Outcomes also include coordinating 3 multicultural connection health fairs annually, 1 in each county, to deliver wellness resources and other healthcare providers to partner with the Route 9 Innovation Library, offering the Hispanic Heritage Health Fair each fall. We provide MCC and health fair outreach attendees with without a medical home, free clinical breast exams from a licensed medical professional and a prescription for their mammogram and any follow-up care that is needed as well. DBCC's outreach also identifies uninsured individuals and assists in their applications to the state Screening for Life program. DBCC outreach connects newly diagnosed survivors via referrals to DBCC's peer mentor and additional internal survivorship programs for the continuity of support and vital resources throughout their cancer journey. DBCC's strategic plan and outreach efforts identify and prioritize those most at risk for disparities in chronic illness and focuses preventing disease through initiatives to increase services in underserved populations for screening, navigation, and survivorship support. Our key outcomes, for those, I'll direct you to pages 5 and 6 for specific target demographic audiences and metrics. But to sum up quickly, those are to deliver culturally competent breast health education and current screening guidelines through multicultural programming to diverse racial ethnic audiences, provide free health screenings in partnership with other health partners, continue a series of programs, activities targeted to women with breast cancer to improve health outcomes by addressing breast cancer survivor topics and evaluating participation of patients for informing our programs for improvement, as well as continuing the Yes to Health program statewide with women and men having 1 or more chronic illness risk factors, such as cardiovascular and breast cancer disease, with a successful peer-to-peer model over a 10-week exercise and nutrition wellness program to foster healthier lifestyle habits. Hosting 3 events relevant to predominantly survivorship issues to mentors and mentees with statewide participation and post-workshop evaluations. The strength of our past outreach efforts speak for themselves, and those can be found on pages 3 and 4 of the application, referring to question 4. For this program, we are requesting a level of $150,000.
Thank you, Francesca.
You're welcome.
Any questions? Okay, great. Thank you so much for the time and to the commitment to serving the populations you work with. James, who's next?
Thank you.
Next, we have Brian Sanders from Delaware Ecumenical Council on Children and Families. Sorry. He's here in person.
Good afternoon, everyone.
Good afternoon.
Good
Yeah,
afternoon.
they can hear you, yeah.
they can hear you.
Just wasn't sure. I would like, thank you for the opportunity to share a few moments with you to discuss a bit about our organization and the wonderful people that we help to care for. If you don't mind, I just wanted to share a brief quote from one of the testimonies from one of our clients. And through it, he says, "For 5 years, I've been told I really needed to go to the University of Delaware Physical Therapy Department, where specially trained therapists in rare neurological conditions could work with me. Over those 5 years, I had no one that could commit to 6 to 8 hours each week, driving me from Dover to Newark, waiting for an hour for my therapy, then driving me home. And I am so grateful that my case manager, Faith in Action, and program coordinator were able to accomplish this when no other federal, state, or other entity could do. I'm almost afraid to tell others about the wonderful work of Faith in Action does, as I'm afraid they will quickly become overwhelmed by need, and I will lose the lifeline I so desperately searched for over the past 5 years. Delaware Ecumenical Council on Children and Family Faith in Action program, our interfaith caregiver program specifically through this application, was originally promoted by the Robert Wood Johnson Foundation and the National Caregivers Network. Sponsoring entities are usually faith-based, and the program mobilizes volunteers and team members to assist persons who are age 60 years old or plus, chronically ill, persons who are disabled age 18 and above, or just elderly whom living independently in their homes is at high risk. The caregivers provide medical and other critical transportation, errand services, physical assistance with grocery shopping, telephone reassurance, and friendly visiting. We also receive and welcome referrals from other interfaith organizations, community nonprofits, and healthcare provider systems in Kent County, Newcastle County, and Sussex County. We are statewide. Our aim is to enhance the continuity of care, help improve their health outcomes, assure that they are feeling safe and well-being is positive, as well as we support independence in their communities. A typical client is female, age 75 to 83 years old, lives alone and functions well on her own inside her home. Her spouse is deceased, she can no longer drive or never drove, and has 2 or more health conditions requiring primary and specialist care. She has no close family members who can help with medical or other transportation. She's not Medicaid eligible because her monthly income is just barely above the maximum level. When clients have increased and consistent access to transportation, to medical appointments, testing, and therapies, they become more compliant with their treatment plans that develop into better health outcomes. Funding through the Health Fund directly impacts accessibility to quality care of our populations. Continued funding is being requested at this time. DECCF will track and measure the success of our programs through our monthly average clients that we reach, track and increase the number of referrals. We do refer fairly actively to Delaware state agencies and refer to community partners as well. And number 3, the continuum of care as reflected in the reduction of the number of client-initiated or missed medical appointments. This is vital as canceled appointments can negatively impact client treatment plans and subsequently their outcomes. Missed appointments can delay other medical care, prescription renewal or evaluation, testing, or specialty care. As most of us know, rescheduling medical appointments with providers can take months, especially for specialists, and could turn delay for receiving vital therapies or surgeries. And also we have enhanced survey data during the grant period to monitor the impact of Faith in Action on client behaviors, their sense of isolation, personal safety, independence, and education we also provide to them on various health topics. I would have one request, mention briefly, is that because we do so much transportation, the mileage reimbursement rate currently in Delaware is 0.445 cents per mile. And the federal reimbursement rate is 70 cents per mile. We're not asking for any matching of federal reimbursement rates, but our reimbursement, I don't know if it's statewide or just with us, has not been increased for over 8 years. And so just for one visit, typical visit, for sometimes a Medicaid patient in Sussex has to go to Nemours and Wilmington for hearing loss care. That round trip is 288 miles. And so the difference between the federal rate and the Delaware current rate is $73 per mile. Tell the $73, that's the difference. And so our team collectively transport patients over 2,500 miles per month. And so that is definitely an impact. So we just brought it up just in case someone heard it. Also, we have need, not through this committee, but just for the persons who are in hearing range, we have definitely need for a handicapped accessible van. If anyone knows of anyone who has one or could donate or share one, we'd greatly appreciate that. So we look forward to being continued partners with the Health Fund and with our community partners across Delaware.
Thank you, Brian.
Any questions? All right, thank you for that thorough overview.
Thank you.
Next, we have Delaware Hospice, and we have Peggy Dolby, who should be on the Zoom now. You should be able to share your screen.
I would love to share my screen, but when I came back from my meeting, I have a brand new smacking service on here. It took me forever to get the Zoom downloaded. So today you get me. But anyway, I just want to thank you guys for your continued support to Delaware Hospice. You guys have been supporting us for a long time, and we truly appreciate it. So Delaware Hospice has been around since 1982. Up to last year, we have served 170,000 patients. And our mission is to support every individual, family, and community with compassionate and expert care for serious illnesses. Delaware Hospice helps each patient each day live the fullest, most comfortable life possible. Delaware Hospice is a leading nonprofit. We're not the only nonprofit anymore, but we are the leading nonprofit serving Delaware, South Chester, and Delaware counties, a little bit into Pennsylvania. One of our problems that we're seeing right now and the need for the request is Sussex County in itself down here, which most of you already know, has busted at the seams. You know, our patient intake has really gone out the roof. And I was listening to the transportation when they were talking about transportation. We just did implement this year our own transportation vans to get our patients from the hospital because that was a problem. You know, we weren't getting our patients. We would get them referred, and by the time we got to them, you know, they were passing in the ambulance. We never got them home. So we started that, implemented it, and made it happen. A lot of our patients are 55 and plus, but if you, on the application, I wrote about Katie Bug. Katie Bug is a fairly new palliative hospice children's program we started. Last year we had, I think, 11 patients, and this year already we have 18. A lot of our patients come from Nemours and other children's hospitals, and most of those patients do have childhood cancers or other serious illnesses that are known before birth and the child is born. We work with the hospitals and the doctors and facilities to get those children home. So that is a program that's near and dear to my heart now, and I did write about that. Because you don't want to have your child in the hospital when you can have them home with something like that with the family. Another one of our costs, which with the influx of folks, is our uninsured care. A lot of people aren't going to the doctors or they can't get into a doctor. Another thing down, a lot of doctors down this way, of course, across the state have gone concierge. So it's really hard to get into a doctor. Some of our patients go to walk-in clinics first and then, get sent somewhere and then get the diagnosis. One of the things which you guys probably already know about this is like no patient is ever turned away for the lack of payment if they don't have insurance. We do get reimbursement, Medicaid, Medicare, and private insurance. A lot of times that doesn't cover anything compared to what the actual cost is to care for that patient and the family. I will tell you that in my 19 years with Delaware Hospice, I was on the backside of how we work, and it is amazing. Nothing was left undone. Nothing. I mean, my mother-in-law had insurance. She had, Medicare and a secondary insurance, but it didn't matter. Everything was taken care of, and that is because of donations and things, our contributions and the money that we receive from the state. That is a blessing that you didn't have to worry about. Oh my gosh, how? And I know I've listened to patients tell that story, and now I know how everyone feels about that. And when your patient is dying, and my mother-in-law had cancer, 3 kinds. So, when you're worrying about things like that, it's just a blessing to have, the funds in a coffer that, we can say to the patient, you don't have to worry about anything like that. The same with our Katie bug. You need to be taking care of
Hey,
your.
I know we're running close up to 2 minutes here, so
Okay,
you want
okay.
to make a final
So
point?
anyway, and our deaths, cancer is one of our top leading deaths here. And so, and with our Katie Bug program, the same thing. What we have programs that lead into like dementia and stuff like that. So that's why I'm requesting $250,000 because our needs for that are over that, but that is a huge help. Does anybody have any questions? Sorry about getting all misty.
So thank you for sharing your personal experiences and for the tireless work that you all do to serve our.
Thank you.
Are there any questions from committee members?
There's a lot in there, a lot of information because every one of our programs help support the end of life, no matter what, from our bereavement to our children's bereavement to everything is all wrapped into that, what we do for the patient and the family.
Great. Seeing no questions from our committee members, we're going to go to our next application, which is the Department of Justice. We have Vanessa Kassab on. You should be able to, there you are. You should be able to share your screen.
I should be able to, but where do I, oh. Yeah, I'm just gonna, sorry, I wasn't really prepared to do that. I'll just work off the slides that I have and give a verbal presentation. So my name is Vanessa Kassab. I'm a Deputy Attorney General in the Delaware Department of Justice. And I am the tobacco deputy for the state. My position is housed within the Fraud and Consumer Protection Division. The tobacco DAG enforces and litigates all aspects of the Master Settlement Agreement, as well as the 2018 non-participating manufacturers Master Settlement Agreement. So we make sure that the funds are flowing in through the MSA and also that the non-participating manufacturers, which is a growing market in Delaware, are doing their required work, their required certifications, and also making escrow deposits into the accounts that must be held for a period of 25 years. The position is mandated by statute and is required to have a qualified statute enforced for payment of MSA funds. And I'll get to MSA amounts in a second. Another thing I do in my position is participating in multi-state efforts that focus on tobacco enforcement a review and give positions to the AG for any sort of proposed legislation that has to do with smoking, e-cigarettes, vapes, et cetera. Not the marijuana portion, but definitely the e-cigs and the vapes section, and also enforcement having to do with those products and those products sales in Delaware. Another thing I led was a successful multi-state lawsuit this year, where our state, Delaware, and a group of over 20 other states obtained a preliminary injunction that prevented the U.S. Department of Health and Human Services planned mass layoffs and also reductions in force that included tobacco-related divisions of HHS. The federal government has not appealed that preliminary injunction, has actually agreed to not appeal it for the meantime. So that is still in place. So we who knows what'll come in the future, but the FDA has not been able to dismantle a lot of the Center for Tobacco Products and other things that they wanted to because of that litigation. As everyone knows, the estimated payment, MSA payment, is going down and has been for a few years now. The estimated MSA payment for fiscal year 2027 is approximately, and again, I say approximately, there are significant unknown variables, but it is approximately about $19.6 million. And that is a reduction, as I previewed a few years ago, of it's been going down about $2 million every year. I do not have the next 3-year predictions yet. The states are represented as our attorney in some issues by the National Association for Attorneys General, and they will come out with a 3-year prediction soon, and that'll give us an idea going forward. The reasons for the decrease and the reasons for the uncertainty is the main reason for the decrease is the volume of cigarettes actually sold. E-cigs, vapes, hemp, legal marijuana, none of this is covered under the MSA. Those companies do not have to pay, are not a party to the MSA, do not have to pay through it. They're under no sort of similar agreement except the non-participating manufacturers, which I already discussed. But again, those are tobacco companies. These other products don't fall underneath that. So within the Consumer Protection Division, we have also pivoted to enforcement of the Consumer Fraud Act as it applies to products that are not covered under the MSA. Rate of inflation always can make this an uncertainty, as well as this. It was always it was a question, and I don't think it is for the next 4 years, about the elimination of menthol. That almost got to the point of being eliminated under the Biden administration. It did not happen, and it almost certainly will not happen under the Trump administration. So good news, people smoking less. Or smoking less cigarettes anyway. Bad news is less MSA money. So my funding request is similar to what it's always been, the salary for one deputy and paralegal. And yeah, so I'm available for questions.
Thank you, Vanessa. Does anyone have any questions?
Vanessa, this is Don Fulton. I know that for, 10 years in a row, there was ongoing litigation that people in your position had to continue to work with. Is there any current litigation involved that potentially can get us additional funds moving forward?
Not through the MSI.
Yeah.
I don't know. I don't anticipate that.
And secondly, do you know anything about the Juul settlement?
Yes, I was lead for the Consumer Protection Division on that settlement.
And how? What's the status of that payment, and where will the funds go in the event that it's successful?
So that settlement was successful. We settled that. I'm sorry, I don't have the year in front of me. 2023 or 2024. And payments are being made as they were scheduled to. That money went into the DOJ Consumer Protection Fund as it was required to under statute. The tobacco fund that was prosecuted through the Consumer Fraud Act, so the money had to go either into the general fund or the Consumer Protection Fund by statute. If future payments are to go anywhere else, that needs to be changed by statute by the General Assembly.
But at least currently, as far as you know, those payments are being used to combat what I consider insidious advertisement and others of electronic and vaping companies that are preying upon children. Are they being
Correct.
used? Okay.
Yes, correct. Yes, correct. Yes, that is a huge concern of the Fraud and Consumer Protection Division. Is the proliferation of e-cigarettes and vaping products on the market. They're targeting towards children, the flavors, how quickly these companies come and go, and they're labeling all these sorts of things. It's a very fuzzy area that we're trying to get a handle on.
Good. Thank you.
Let's add one more question.
Mhm.
As we are going through the tobacco funds, and also, as you know, I don't know whether you're working on it or not, but we have the opiates dollars coming in. And I do know that because I serve on the opiate commission also. So based on all that, is there any possibilities? This is for Christine, the secretary, is there anything that we have an overlap? Is there some of the programs that we fund, for example, the behavioral health, maybe there is funding available somewhere, and I didn't know how all that would work out. Usually when we request money for the behavioral health, they are coming from the general funds. Time and again, they take it out of this fund. So sort of kind of a little unclear bookkeeping, but since we have those resources coming in, I just wanted to make sure that bring it to the secretary's attention that we have two separate parts.
Yeah, thank you for that. I know the mechanism there is separate, and there's a sort of different state versus local approach, but it's a great flag as we think about the sort of long-term transitions here.
Thank you.
Anyway, one final word. Thanks, Vanessa, for all you do to help keep this money coming in.
Thank you. Yep, we have had no reductions since I have been the tobacco DAG. We've gotten our full payment every year and on time, and there's no reason we shouldn't be able to keep on doing that.
Vanessa, keep doing a good job. Thank you again.
Thank you.
Thank you, Vanessa. If there's no other questions from committee members, next we have Kevin Jones from DATE, Delaware Alcohol and Tobacco Enforcement. Kevin, you should be able to share your screen. There you go.
Good afternoon, everyone. I don't have anything to share on the screen, but so you just have to deal with me, I guess. I want to thank everyone for the opportunity to speak, because this will be the first time I've actually had the opportunity to personally address this committee. As you said, my name is Kevin Jones. I am the Deputy Chief for the Division of Alcohol and Tobacco Enforcement, commonly known as DATE. DATE is a state law enforcement agency. We have an authorized strength of 31 sworn police officers along with the 2 civilian staff. We are responsible for the investigation and enforcement of state laws related to alcohol, adult use marijuana, and one of our primary functions remains the enforcement of Delaware's youth access to tobacco laws. Our division administers the Tobacco Enforcement Program, which is responsible for enforcing state law prohibiting the sale and distribution of tobacco products to individuals under the age of 21. This program ensures the state's compliance with the federal SINAR amendment, which is administered by SAMHSA. Core activities include conducting annual random and unannounced compliance checks through our cooperating underage witness program, and maintaining a statewide retailer non-compliance rate of 20% or lower. DATE's Tobacco Enforcement Program directly supports tobacco prevention and control by reducing youth access to tobacco products. Our Cooperating Underage Witness Program conducts annual, random, and unannounced tobacco compliance checks at retail establishments statewide to enforce our state's tobacco laws. By ensuring compliance and limiting youth access, our program directly contributes to preventing early tobacco use, reducing long-term health consequences, and supporting statewide tobacco prevention initiatives. Some of our key outcomes will be our officers conduct visits to all newly licensed tobacco retailers and provide them with education materials and legal notices, which result in improved retailer knowledge and voluntary compliance with state tobacco laws, resulting in fewer violations. Our officers also complete at a minimum 200 random unannounced compliance checks throughout the state. These efforts continue to reduce illegal tobacco sales to minors, which in turn lowers youth access and support long-term health improvements. In 2024, our division demonstrated continued and measurable success in reducing youth access to tobacco. The statewide retailer non-compliance rate was 8.84%, which is well below the federal SINAR threshold of 20%. At that time, there were 233 unannounced compliance checks statewide. And 100% of newly licensed retailers were also visited, which resulted in fewer repeat violations and improved voluntary compliance. In addition, we also trained 3 new youth inspectors, which are cooperating underage witnesses, which contributed to more accurate inspections under the supervision of a sworn police officer. The Date Tobacco Enforcement Program also ensures the state meets the requirements of the SINAR amendment administered by SAMHSA, which is necessary for the state of Delaware to receive the full substance abuse and treatment block grants. Our funding request remains generally the same. This funding provides 4 full-time employees, 3 of which are sworn police officers to conduct the compliance checks, as well as 1 non-sworn employee as well. The increase over previous fiscal year is a result of increased salaries through our officers' collective bargaining agreement. Any reduction in health funds could potentially have significant challenges for us and could jeopardize some of our ongoing efforts. So we would respectfully request our funding request be authorized by the committee. Thank you. And I'm open to any questions anyone may have.
Thank you, Kevin.
So Kevin, this is Don Fulton. I got to say thank you to you guys as well. Prevention is so critical to this whole process, and 8% compliance is like unheard of. I'm pretty sure. My only question to you is, and this is unofficial, but I can probably, within walking distance of my front door, I can probably go to 10 places that sell cigarettes. How can you do your job with 31 people?
Well, I say we have 31 people, but up until about 2 years ago, we had 17, which includes administrative staff. The increase to 31 is largely due to the recent adult use marijuana legalization, which essentially doubled the size of our agency. How to answer your question, short answer, we do it. We have a dedicated group of people here. We carefully vet our applicants who look to work here to make sure that we're hiring only the best. And these people are dedicated and believe in their jobs. And we're all parents. We don't want any. And personally, I have experience with my relative. My mother has smoked for 60 years. I can't get her to stop, and she's dealing with the health problems of that. So I take it personally as well, that this effort. So our people are out here constantly doing what's expected of them, and they do a good job at doing it.
Well, thank you, because you're a really important part of this whole process. And I hope your people know that as well.
Thank you. I appreciate that.
Thank you. Seeing no other questions, and then we have a couple of applications from the University of Delaware. We have Susan here, and Alicia was on the Zoom there you go. Alicia, you should be able to
Yep, I'm
share
here.
your
Can you
screen
hear
as
me?
well. Great. Yep.
Okay, let me go ahead and get our share up. Thank you. Okay. Everyone see that okay?
Yes.
Okay, great. Sarah Mallory's in the room with you, and she's going to talk us through this, and I'll move the slide.
Hi, everyone. As you heard, my name is Sarah Mallory. I'm with the University of Delaware Center for Disability Studies. And along with Alicia, we lead the Delaware Network for Excellence in Autism, or DNEA. So the DNEA was established in 2016 by Senate Bill 93 to provide the community with training, technical assistance, and information dissemination that focuses on individuals with autism and the evidence-based practices that can be used to support them. It's housed at the University of Delaware Center for Disability Studies, and a portion of our funding is used to support Autism Delaware's direct services to families through their family navigation program. So just a snapshot of why does Delaware need the DNEA? People with autism are more likely to have co-occurring mental health, medical and dental needs, and also have an increased risk of co-occurring chronic health conditions. On top of this, they experience really significant barriers to accessing healthcare. Of note, professionals are often have difficulty treating this population either because of limited professional training, a lack of confidence, or general misconceptions about disability. And we see this in our training numbers. I've shared the last 4 years of training along with the funding amounts that we received. And for the number of folks that we've trained, you can see that only 4 years ago, we started with 437. In this past fiscal year, which just ended September 30th, we trained over 3,000. Our reach this past year is over 18,000 people and growing. And we train any and everybody. Not only are we supporting autistic Delawareans and their family members, but professionals who support this population across the lifespan, with some of the folks that we work with here on the slide. So we have submitted we have some public comment that was submitted on our behalf. Alicia's going to drop a copy of it in the chat for us. I also have some paper versions that I could submit for you as well. I know that you were emailed them all, but I figured it'd be helpful to put them all together in one bundle. What these really show is the really strong network that the DNEA has with its partners. Not only are we serving a wide range of partners, but we are also collaborating with a wide range of partners. Autism Delaware, as you heard, but also folks like Nemours, University of Missouri, and DDDS and DSAM and other agencies in the state. Some of the activities that are noted on this handout that I gave you are things like our autistic drivers and first responders work, where we are doing practice traffic stops. We're supporting the dissemination of Delaware's Blue Envelope program, which you may have heard about in the news recently. We also are supporting ECHO project with Nemours, which focuses on early identification. Our state has very, very long wait lists in order to be able to get an autism evaluation, which holds up a person's ability to get intervention for their child. We work with early childhood professionals. Of note, we are supporting the implementation of HB 202, which is our state's developmental screening initiative, by offering a training that's mandated for all childcare providers in the state. And we've also done some work with mental health providers. This is just a snapshot of some of our work. As I said, we just finished up our FY25 contract, and our full report will have more once we publish that in the next couple of weeks. In terms of our goals, our goal areas are largely driven by the legislation that established us. I took a snapshot of them from our proposal, but I highlighted kind of the keywords here. Our largest goal area is related to training and technical assistance, as that is the primary focus of our work. We evaluate our training and technical assistance at multiple levels. First, through very basic training satisfaction. How did you like our training? Our scores for last year, with 98% of attendees reported that they were satisfied with our training. We also conduct pre and post knowledge assessments and asked trainees to report on their knowledge gain and their ability to apply evidence-based practices. These are gathered immediately after and 2 months after a training. Our early results from FY25 are showing a statistically significant increase in knowledge across all measured areas, often by multiple points, and we're looking to sustain this for our coming year. Finally, we also, at our deepest level, go back to level 1, please, also evaluate through pre and post knowledge assessments, which we are launching in FY26, and surveying agencies and organizations about how they are using the evidence-based practices and resources that we shared with them in their work with the autism community. Of note, 100% of organizations who we surveyed, or mean a 3.5 out of 4 on a Likert scale, reported that they had an improved understanding of their autistic clients and that they were able to better serve and include these clients in their services that they offer the community. Our second goal area focuses on resource dissemination, which again is another one of our main deliverables in the legislation that established us. It focuses on recipients' satisfaction with our materials, as well as the frequency in which they are referencing these materials. For example, in FY25, 91% of organizations who were surveyed 2 to 6 months after receiving a training series from us reported that they continue to use our resources to serve their clients after the training. Our targets for FY26 and FY27 are looking to sustain and increase these numbers as well. And goal 3 focuses on the work of our partner, Autism Delaware, and their services providing family navigation. They are developing a post-service survey this coming year in order to be able to measure the impact with their clients, and it will be launched in FY27. And finally, goal 4 is a little bit of a catch-all of other activities that are outlined in the legislation that the DNEA is required to be able to facilitate in the community. Primarily, these deal with facilitating the Interagency Committee on Autism, or ICA. And this is measured by public meeting records showing that we held the meetings, that we maintained minutes, that we organized it. I serve as the administrative co-chair, so I'm a non-voting member of the ICA, and we are responsible for keeping the ICA organized and running all of its meetings. So our funding request is to maintain what we had last year at $460,000, as this is HFAC has served as DNEA's primary source of funding since it was established. And I'm happy to answer any questions that you have.
Any questions from folks? Okay, wonderful. Thank you so much to all of our presenters. Before we move to public comment, I want to talk a little bit about next steps and try to facilitate some discussion here. James, that was everyone, right? Did I miss one?
Yes, that was everyone.
Okay, great. I saw some heads in there. Wonderful. So I want to try to facilitate a little bit of discussion so we can get closer towards making decisions on our required timelines. We obviously have more work to do on the healthy communities piece of this. We will go back and figure that out. I apologize for my newness in this space, but we will come back and figure all of that out. So next time, I hope we will have answers there. Beyond that, I would like to get the committee's sense of where we want to be in terms of carryover balances at the end of this year. Are we looking to maintain roughly the $12 million carryover that we had at the start of this year, sort of limiting ourselves to spending new monies? Are we looking to spend down the carryover as incoming funds dwindle? It would be great to get a sense from folks of where people's heads are for this year. So let me open it up.
Well, I've been a vocal supporter of maintaining a reserve balance for a long time. In fact, I've encouraged this committee to actually add to the reserve balance each year to offset the fact that funds are dwindling. So at worst case, in my opinion, we should keep the reserve balance at least where it is presently.
And I echo that.
Any other thoughts from folks? Okay, all right, that is clear direction. The other sort of big structural question that I want to put to folks is sort of how to think about the balance between new and existing grantees. And I would love the benefit of others' experience, sort of having gone through this in the past, and and how folks are thinking about this generally.
Good afternoon again. This has been one of my comments every year, is that I'm never a fan of supporting things just because they're legacy applicants. Even if we aren't able to get to a resolution this year, I think we need a firm application with a rubric that we're able to critically assess applications on their merits, and if they're legacy applicants, based upon their outcomes as well. Every year, because of turnover, we haven't been able to get over the threshold and creating that rubric, but that's been the discussion for the last 2 application cycles.
So I'm going to speak and also try to be mindful of conflicts. That I think it's hard to talk about the reserve as a hard line as far as previous when like, you know, sort of blindly, like not really us having gone through each of the line items yet to really be able to see which program with which amount of money, you know what I mean? Like that's kind of hard. So not going to really weigh in on that other than just to kind of throw that out there. And, you know, I know Dr. Lee and I have mentioned this in previous, and I'm going to say it again. And I think that's the case. It's just legacy doesn't really make sense. That's not a part of the grant, like at all, period, to say that if you've applied once before, you should sort of automatically be rolled in year after year after year. Like, you know what I mean? One, is your program doing what it says that it's, you know, supposed to do? And I don't know that we have really even been very stringent on that, right? So some of these programs that have applied year after year after year, I don't know that we have really held them accountable as far as showing us, have you done what you said you were going to do while you're requesting the same, if not more, funding? And so I think that that's something that just in general, the committee should really consider and think about moving forward, especially as funds are starting to dwindle and we have to be more selective about who we're funding and how much we're funding, that really be, if you've applied 6 years in a row and you can't really show where you're hitting your metrics, that should be taken into account. But I just leave it at that.
That's helpful. Other thoughts from people?
Well, I will say this, we spent a lot of time 2 or 3 years ago updating the application. And we added significantly to the requirement of showing metrics and, you know, as best as you can with your particular project, that you're meeting your goals each year. So I think we have done some of that. Now with that said, we don't look at, other than individually, we don't look as a group at each application, and maybe that's something that we can start doing. But I will say this, the amount of data that we're getting now is so far above what we used to get in terms of meeting your expectations and your goals each year and justifying, if you will, the contributions you've received from the health fund.
Senator Porter, did you have thoughts?
I apologize. I ended up getting kicked off, so I am coming in mid of this conversation. But what I'm gathering is just about the fact, I heard Autumn's comments in regards to making sure that people are showing their metrics and it shouldn't just be a rollover. I think ultimately what sometimes people don't remember is that their programs are supposed to evolve. And when we are incentivizing, whether it's agencies, nonprofits, nonprofits are the largest employer in the state of Delaware. And it certainly is a huge help to the state of Delaware when we have these organizations out there doing the work that we'd all like to do full time with millions and millions and millions and billions of dollars. But that being said, monies have to come from different areas. And as times get tight, the grant application should never be the same. It should always be about that next level of who you're reaching and how you're reaching. So coming in last minute on this, that would be my 2 cents. I apologize. Technology issues, gotta love it. So that's my statement.
Great, great. That's very helpful. Okay, so then what we will try to do with the DHSS team, one, we are going to get an answer on this $1.5 million for healthy communities and come back to you on that. And we will try to put together some scenarios for the next conversation that that reflect a little bit of the values that I'm hearing here. I would, with the goal of getting to about, a little over $19 million in spend. I would love it if others could spend some time with the spreadsheets between now and our next meeting as well, and sort of put together your own thoughts on how we might get to $19 million, so that we can have a little bit more focused discussion the next time we all meet. And James, we have an additional group of what, about 10 presentations next time as well?
Yeah, we actually, so that was exactly what I was going to bring up. We have a little over 10 presentations for our next meeting, which does not give us a lot of time to have that thoughtful conversation to the level that you guys all just said that you would like to have. So what I am not a voting member, but what I would like to pose is whether or not the committee feels it would be necessary to have another meeting the following week before the 15th.
And the minutes of August board meeting? September. Thoughts, folks?
Yeah, I'm sorry, James, can you just, and I apologize because I'm sure you sent this out because you've done an amazing job. So my apologies. The 10 or so that we're going to see, those are previous applicants, or are those new applicants, or they're a mixed bag?
It's a mixed bag. We're just going through them in alphabetical order from,
okay.
So it's basically just the remaining ones that we haven't gotten to, understanding that we've gotten to about just over 20, I believe.
Okay.
Yeah.
It's so hard to hear. There's someone with background feed. If everybody can mute.
Yep, we got it. I'm not opposed to having an additional meeting to allow for more of discussion. Personally, I'm okay with that.
I agree with that as well.
Me too.
Okay, so that meeting would then, and especially just to give us time, would need to be in the beginning of the week of November 10th. So what I'll do is right after this meeting, I'll send out a doodle poll for the 10th, 11th, or 12th for people to be able to do it. So either the 10th or 12th will be either of the days. I'll send out a couple of slots that work for folks.
The 11th is a state holiday, so we will not be doing it that day.
Great, okay. We are over time and we still need to take public comment. James, I'm gonna let you give instructions here on what folks should do. And we will follow up in writing to committee members to get our supplemental meeting.
Absolutely. So now we're going to go to public comment. If individuals would like to provide public comment, thank you. Yeah, feel free. Just for everybody who is leaving at the moment, please just make sure you sign out at the front desk as well. Thank you so much. Yeah. Sorry about that. For everybody, for anyone who is on and would like to provide public comment, each individual will be allowed to do so in the order in which that they will indicate. To indicate, please use the raised hand function at the bottom of your screen, and we'll call on you in the order in which you raise your hand. The first person we have is Deb Brown. Deb, you should be able to unmute yourself now.
I could, thank you. Well, good afternoon, and thank you for the opportunity to make comments. My name is Deb Brown, and I'm the Chief Mission Officer for the American Lung Association, and also serve as the chair of the Delaware Cancer Consortium. And I just want to say how much we appreciate the committee's thoughtfulness and strategic approach to recommending the allocations for the health fund. We know that there are many important programs funded through the Health Fund, and difficult decisions are being made through this process. I do want to encourage the committee to continue to support and prioritize funding for tobacco prevention and cancer programs, which was really the original intent of the Master Settlement Agreement and the Delaware Health Fund. These funds are really integral to ensuring that Delaware continues to stay healthy and tobacco-free and combat new and emerging products that are attracting and addicting our youth, like electronic smoking devices and nicotine pouches. So again, I just want to say thank you, and happy to answer any questions further or in the future if you need.
Thank you, Deb. Next, we have Kate Phillips, and I did forget to mention this. That's my apologies. Each individual has 2 minutes, so we will be cutting people off. Kate, you should be able to unmute yourself now.
Great. Can you hear me?
Yes.
Okay, wonderful. Thank you all so much for your time and consideration. I really appreciate it. I know that it's a difficult and confusing process from year to year. So I appreciate your consideration of kind of working out the questions on Healthy Communities Delaware, as well as the Innovation Fund. The Innovation Fund has historically been a separate $1.5 million budget line that is entirely invested in the lowest income communities across the state with the poorest health outcomes. I understand that it's not scheduled for a presentation, but I would love to have the same 2 minutes as everyone else if possible at the next meeting, and I can share the impact of those funds, which has been significant. Thanks for your consideration.
Thank you. Next, we have Brian Hall. Brian, you should be able to unmute yourself.
Okay, can everyone hear me?
Yes. Yes. Oh, Brian, you should be able to unmute yourself now.
Are we good?
Yes, we can hear you.
Okay, great. Again, I'm Brian Hall, the Executive Director for Autism Delaware. And I just wanted to take a moment, just first of all, to share that I'm so thankful to have Sarah Mallory kind of stewarding our relationship regarding D&EA, and that since the start of this, one of the things I think folks sometimes forget is that families who are experiencing autism don't always know where to call. And through the support of D&EA, we've been able to expand that service throughout Delaware and enabled families to link up with other groups that, in fact, are on this phone today or in this meeting today. And I think no matter, what happens in this process, we always have to keep in mind that the resources dedicated to families being able to talk to other families, being able to find other providers in the community is key to helping us sustain our communities. And I don't know what will happen. You all have some challenges ahead of you, but I always want you all to remember that we do need folks who are helping other folks by holding hands and walking them to the doors of other practitioners and providers in the state of Delaware through difficult times. Autism Delaware remains that key piece for those autistic individuals, but also we support other communities as well. They just got to call us, and we supported them. So again, thank you for your time, and appreciate all the effort that's going into helping us figure out the challenges that lie ahead.
Thank you, Brian. And I do want to flag that our chair may need to run. So if she needs to, we'll be able to adjourn the meeting right after. We do have one more public commenter. It is Lance Kilpatrick. Lance, you should be able to unmute yourself.
Thank you, James. And thank you, Madam Secretary, Madam Senator, and the rest of the advisory committee. For the record, my name is Lance Kilpatrick. I'm the Government Relations Director for the American Cancer Society Cancer Action Network. In the interest of time, let me just say I completely echo the comments that Deb Brown from the American Lung Association so expertly and intelligently made. Thank you.
Thank you, Lance. And it looks like Secretary Young just got off. So we will need to have somebody entertain a motion to close the meeting, adjourn the meeting.
Make a motion to adjourn the meeting.
Do we have a second?
Second.
All in favor?
Aye.
Motion carries. Okay, till we meet again in the beginning of November, we hope that you have a great rest of your week and please stay out of the rain that's coming. Have a good one, everyone.
Bye now.
Bye.